Hello and welcome back to another show of Visions for Health. I'm Wendie Trubow, and my guest today is Dr. David Danforth. He holds a PhD from Boston University and is a clinical health psychologist. Welcome.
Thank you for
Thanks
having
for
me.
being here.
It's good to be here.
So before the show, you were telling me some funny stories, but let's start with the basics. What is it that you do, and how did you get into it?
Well,
That's kind of a big question, I know.
Yeah. At the very core, I help people to feel better and to get more of what they want from life at an emotional level or a psycho-emotional level. I do a number of things within the context of clinical health psychology, or what could be called medical psychology or behavioral medicine. And that often involves integrating pieces of different theoretical orientations as well as techniques from various schools of psychotherapy.
So what does that mean?
Well, let's say in cognitive behavior therapy, which is very often used nowadays, we might help people to alter their behaviors, to alter the way they think about situations, to alter the way they actually talk to themselves and approach situations. If they're having trouble with medical or physical symptoms, we would help them to alter how they actually cope with those symptoms and on a day-to-day basis.
So the way people approach certain situations, the thoughts they have in situations or leading up to them, and then their reactions to physical ailments.
Exactly.
That's huge.
It's pretty comprehensive.
And cool.
Yeah. Well, there are essentially two, these days, polar theoretical orientations, more of a psychodynamic one, which is perhaps what people think of when they think of psychotherapy.
Okay.
And this is also called insight-oriented psychotherapy. It evolved from psychoanalysis. And then the cognitive and behavioral schools of theories, where we look at both how a person thinks and how a person behaves, and also about how they feel about how they think or behave. We can integrate, and in integrative psychology and as in integrative medicine, we're thinking about how to integrate the entire person into the psychotherapy. Above all, I think psychotherapy is a collaboration, as is any kind of doctor-patient relationship. So that when patients are done with treatment and they say, well, thank you for helping me, I always say, well, if it's opportune, I say, well, thank you for allowing me to help you.
Being of service.
Yeah.
How'd you get into this?
Oh, well, it's a very long story. At the very beginning, I was 8 years old, and I was given the complete works of Sir Arthur Conan Doyle and started reading Sherlock Holmes avidly.
At 8?
At 8, and I
think you were reading above your reading level there.
A little. But I appreciated, the hypothetico-deductive process. And at the same time, my grandfather in Vermont, who was a dowser, would take me dowsing with him sometimes and taught me to dowse.
So for
this
our
is the
audience, that may sound like fishing in Vermont, but that's not what you mean, right?
Dowsing is when you hold a little wand in your hand, in your fingers, and you walk along and you walk along, and when you come to a water source, the wand kind of points downward. Now, this is not exactly scientific. And so I was struck by the juxtaposition, the coming together of both hypothetico-deductive reasoning in Sherlock Holmesian terms, and how somebody can find water holding a stick. So it was really astounding, and it made me think, well, there's more to things than meets the eye. Mm-hmm. And I guess that was the very beginning of when I was interested in psychology.
And then, did you go to school with the idea that you would be a psychologist?
Not at all. I actually was in the 6-year medical program at Boston University. Mm-hmm. I was planning on becoming a family physician, an internist, and just like Dr. Farmer in St. Johnsbury, Vermont, where I was born, And after the first couple of years of that program, I took a leave. And when I went back, I decided I'd just finish off my degree in psychology, and then worked for a while doing research, and decided when I went back to graduate school that psychology was what I wanted to do. But there was a glitch.
But wait.
But wait, there's more. Initially, I thought I wanted to be an academic psychologist, a professor. And then
You have that kind of way of being and demeanor. Like you could pass for one.
I could? Oh,
You could play one on TV.
I play one on TV, exactly. But then I decided I didn't really like teaching and scoring exams and papers and the whole publish or perish life of academia.
The job itself.
No, I wanted to be with people more and help people. So I went back to the medical school, where there was, at the time, one of 3 programs in the U.S. in the Department of Biobehavioral Sciences that was then directed by Dr. Lyle Miller, who I believe is now retired, but he was a wonderful man and had founded this unit where he was doing research and clinical work with people with what was then called psychophysiological disorders, like headaches or certain kinds of musculoskeletal pain. For instance.
Physical manifestations of emotional imbalances or emotional pain?
When both things, mind, body, coincided at the same time, simultaneously. And we got to look at what was going on inside the person, physically and biologically, as they were talking about things. One case I presented once at Grand Rounds was of a nurse who had a very rare disorder where her blood pressure would suddenly plummet and she would pass out. And in monitoring her and talking with her, I found that in discussing any sort of argumentative situation, this would happen. Her blood pressure would go up and then it would suddenly plummet. This is called a vasovagal response. And more than that, to integrate the psychodynamic part, the insight part that I mentioned earlier, it became clear that her mother had passed away and she had never had a chance to see her mother before she died. So she had no closure. There were a number of issues that had estranged them over the years. And when she talked about her mother in one of our psychotherapy sessions, not only did her blood pressure get very low, but she came very close to passing out, even though she was sitting down. So things like that were very, very interesting to me. Then later, the cognitive behavioral psychotherapy movement became stronger. There became a very rich literature, research literature, using, among other things, randomized controlled trials of cognitive behavior therapy and comparing them to use of medication, let's say, for depression or anxiety, as well as other kinds of psychotherapy. And it was found that it was equal, if not better, than medication or other forms of psychotherapy in some circumstances. So I did some training in that as well. And that includes an interesting aspect. I got a chance to do training in hypnosis.
Cool.
And in something called brief cognitive hypnosis, as well as something called Ericksonian hypnosis. Milton Erickson was the sort of the proponent, the founder of Ericksonian hypnosis, and it was a way of doing hypnosis very gently by telling stories and using humor sometimes, and using imagery and suggestions embedded in the stories and the humor to help the person to make the connections at a much deeper level.
So I have a number of questions about this.
Oh.
One is, did you receive hypnosis to know what it was like?
That was great. It was the best part of my training. I got to do almost a year of hypnoanalysis of my own.
The recipient.
I was the analysand, the hypnotizee, and it was wonderful. I really enjoyed it, learned a lot about both myself and what it's like to be a patient. and it was very useful going forward.
When you say that you're telling stories and they're interspersed with humor, are these set stories that someone has written, or is this a training that you've been taught how to do, and then there's a cadence and a pattern to it?
Well, of course, most of us who studied Milton Erickson read a lot of his case histories, but I just make them up as I go along. And as I've been practicing over the years, I sometimes have a few that I like, and other times I make them up just bringing them out of my experience somewhere.
So it sounds like there's almost a third component. There's the cognitive work, there's the aha moments, there's the hypnosis, and then there's the behavioral component. So you have an aha,
Yes.
you have an opening, and then you have some kind of behavioral change.
Yes, and always, not always in that order.
I like that order.
Yeah, well, I do too sometimes. For some kinds of problems, we call them presenting complaints or presenting problems, people will come in and have a specific problem that they want to tackle. And at Visions, what I've been doing is creating a very short-term treatment model where I'll see someone for an initial appointment, get to know them, ask them a million questions, and then try to decide what it is we really want to focus on. And then we take about 5 visits and focus just on that problem, measuring as we go and seeing how the person's doing, and making adjustments as we go. Sometimes that could be simply behavioral. And I won't use any examples from my work at Visions, but here's an example. A man came to me once when I was working at Beth Israel Deaconess, and his internist had referred him because he had high blood pressure and he was pre-diabetic. He was also quite overweight. Turned out, as we talked, that he had what he called an addiction to chocolate. In fact, it was so bad he couldn't even go to fill up his car at a gas station because, as you know, they have all these little mini marts, and he would go inside the mini mart to pay for his gas, and he'd stuff his pockets full of chocolate bars.
Sounds like he needs a debit card.
I don't think he would have used one, you know?
Right.
Or unless it was chocolate, and then it wouldn't last long. See how the stories evolve?
Yeah.
Anyway, his problem was that he wanted to stop eating chocolate. And it turned out that we could do something using both a psychodynamic piece and a behavioral aversive conditioning piece. In behavior therapy or behavior modification, we use reinforcements of various kinds. Positive reinforcement, everybody knows, is reward. Negative reinforcement isn't punishment, it's taking away a noxious stimulus, a bad something that makes the person want to do something more. And then there's punishment, of course, or something that's aversive. In this case, he told me that he hated radishes. And the reason he hated radishes was he was at summer camp one year, and they were served salads, and he ate radishes, and for whatever reason, he could have been allergic to them. He started vomiting whenever he would have his salad with radishes. But the staff made him eat his salad. Yeah, poor guy, had to eat salad and would end up vomiting. Well, he figured out ways of palming off the radishes, but he was left with this enduring feeling that radishes for him were poison. Guess what I did?
Chocolate radishes?
Exactly. So taking this little piece of history, we taught him hypnosis and taught him self-hypnosis, and then talked about how in hypnosis he could think about what it was like to eat radishes every time he reached for a chocolate bar or a piece of chocolate. And within 2 weeks, he'd stopped eating chocolate entirely. His A1C, his pre-diabetic levels went back to normal, and he felt fine, and he lost a lot of weight. So that's an example of integrating techniques from one or another school of psychotherapy in a way that's prescriptive and helps the whole person.
Are there people who are easier to hypnotize than others, and other people who you can't hypnotize? Like you've just not been successful at it? Or?
Well, that's another interesting question, Wendy, because until the 1970s, more or less, hypnosis was thought of as a susceptibility. This goes all the way back to Friedrich Anton Mesmer in the mid-1700s, who did his doctoral work on animal magnetism. And it was thought that, or he espoused that some people had strong animal magnetism. They were, of course, all males. And others weak. So the strong...
All females?
Yeah, probably. The strong-willed people could exert their will over the weak-willed people. And time went by. This was debunked. And it was later... there was another debate that I won't go into because it's technical. But then it began to dawn on people that perhaps this wasn't a susceptibility. Perhaps it was an ability. And there was a psychologist here in Massachusetts. Excuse me, I have allergies. A guy named Ted Barber, who was a psychologist here, and his research group and others around the country found that indeed hypnotic susceptibility was not the case. We all have a hypnotic ability. It does correlate somewhat with intelligence, especially creativity and the ability to imagine, to suspend critical thinking or editorial thinking and engage in fanciful thinking. And perhaps that's why children, kids, are better at hypnosis than adults, because as we get older we become more editorializing of ourselves, of our lives, and of others.
We socialize the ability out of them, is what you're saying.
More or less.
Yeah, in a kind fashion.
In a nice way, yeah. One of the first cases I treated on an emergent basis was a young boy who lived upstairs from me at the time. And he'd been rollerblading around his house and accidentally put his arm through a window. Oh. So he had some very bad lacerations in his arm. And he was screaming, and the mother was very upset. And I went upstairs and suggested she call 911. And I immediately...
I'm sorry, that wasn't a hypnotic event, right? That wasn't...
No, that was like, call 911. But then I started trying to calm down this little boy and said, the previous winter, he and I had been outdoors and we'd made snowmen. And I said, remember when we made snowmen? And he was screaming, yeah, yeah. So I said, let's imagine we're making a snowman and we're rolling a snowball and making it bigger and bigger. And now you're going to lift it up with your arms and you're going to put it on the ground and we'll roll another one. So we rolled the snowman and he was hugging the snowman. And I suggested that his arm would feel so cold from hugging the snowman. And it did, and he calmed down. And then the EMTs arrived.
And that was the end of the calm?
Yeah. Well, he was fine. He went off to Newton Wellesley Hospital.
Okay. That was your first time ever?
That was the first time I used it in an emergent basis, yeah.
And then what was his, have you spoken to him since about looking back on that event? If it gave him any power to move forward in
and I didn't really do follow-up on that one. Soon after that, we moved.
Got it.
And I didn't really get a chance to follow up.
What do people say about their ability to self-hypnotize as they move forward in crises, events, whatever that may be?
I suggest at first that they keep it simple. And when they go home, self-hypnosis is a little bit like meditating. I also teach meditation to patients of various kinds of meditations. And self-hypnosis is a bit like meditation. So after practicing it a bit, the person becomes a little better at it. Not beyond their innate ability, but up to their ability. And they find that they can do it with fair ease. The suggestions, though, we like to keep simple. So if we're working on a particular problem, they may imagine themselves giving themselves a very simple verbal suggestion, as though you had a cue card.
Can you give an example of this? So is it someone who engages in self-sabotaging behaviors, so there's some cue card there, or what's the context for people?
It's easier to give someone or have someone give themselves a suggestion to do something they'd like to do rather than not to do something they wouldn't like to do. So finding a positive competing behavior goes back to behavior modification and counter conditioning. So one counter conditions a positive behavior to supplant or take the place of something that's unwanted. Recently I worked with someone who really knew that she needed to go to the gym and work out for medical reasons, as well as for emotional good health. Yet, for various reasons, couldn't bring herself to do that. I suggested that maybe when she went to the gym, she could bring something that she wanted to read or a book on tape that she wanted to listen to. And only under those circumstances could she listen to or read that material. So that was the positive reinforcement. And that overtook and was strong enough to motivate her to go. It overtook her aversion or her reluctance to go to the gym. And there were other reasons why she didn't want to go.
All right. How long do people typically take to... I think the hypnosis is fascinating. And how long
You're
does
really
it...
into the
Yeah,
hypnosis,
I really am, because I can understand talking therapy. I can understand looking for an insight. But I don't think I've ever experienced being hypnotized. I certainly know of hypnotic events. I know about the Mad Russian in Brookline. So I just find this fascinating. How long does it typically take people to learn it? And how much practice is involved in getting good at it for self-hypnosis?
Within the first session of actually doing hypnosis, a person can learn to go into a hypnotic waking state or a hypnotic trance. To practice on their own doing self-hypnosis is usually something that comes a bit later, after 2 or 3 sessions where they're doing it with me as the hypnotist, the hypnotic agent. And then I give them homework to practice at home. The point you make about insight is, long ago I coined a phrase about insight therapy because I was originally trained in something called ego developmental theory and psychodynamic psychotherapy. And my mentors and supervisors were psychoanalysts. So I actually conducted some psychodynamic, psychoanalytic type cases. But I realized that as a psychologist, I can lead someone to insight, but I can't make them think. Right? So the behavioral component sometimes is a way of, once they have a kernel of insight, it helps them to think or to make use of that insight. And to complete the pun, to drink the water. Not the Kool-Aid, the water.
Right. I always say to my patients that knowledge is not the access to power, because if it were, everyone would be leading lives that led them to healthy outcomes.
That's true.
So knowledge certainly isn't. So that's why I feel as though insight is similar to that.
Well, as Homo sapiens, we are sentient beings. A sentient being is one that has senses. And we have all of our senses, and some of us have extra senses, the sixth sense. But we're called Homo sapiens, and sapiens means sapient. We have wisdom.
Hopefully.
Hopefully. Well, that's the point. Not everyone has wisdom to begin with. We hope that we acquire it. as we mature.
Do you see children now in your practice?
In my private practice, I sometimes see adolescents. At Visions, because of the hours I'm there, I usually don't.
Okay. What's the youngest age you're comfortable seeing as a patient?
In my private practice or Visions?
Well, if it sounds like if Visions had different hours, you might see them there. It's more
middle schoolers, high schoolers, often with social school phobias or phobias of some kind.
Mm-hmm.
I've seen a lot of kids for phobias of medical procedures or social anxiety at school, and things like that. I don't treat children with depression. I leave that to people who specialize in child psychology or psychiatry.
That makes sense.
Yeah.
What about with adults? Is there any particular focus that you have in terms of, oh, I love treating this or I love treating that?
I love treating people who have a sense of humor, even if they're depressed.
How do you screen for that?
I actually do. During the initial interview, I use humor as a way of sort of pinging the person to see if they'll respond to humor. And that, along with some basic psychological testing, is a good measure of degree of depression in people who are depressed. In people who are severely depressed, they usually don't respond to anything humorous. And there are other ways of telling, distinguishing degree of depression. I work with all sorts of people, ranging from people with anxiety disorders of various kinds to obsessive compulsive disorders of various kinds. People with some people who have depression, either unipolar or often bipolar type 2 depression, where they don't become extremely manic but become somewhat less than that, and often have irritability as one of their mood states that they don't like. Yeah.
As we are coming to the end of the show, did I miss anything? I didn't ask you about insurance. Do you accept insurance?
At Visions, we accept all sorts of insurance, and we have a very, very wonderful billing staff who takes care of that. Some people will need referrals, depending on if they're an HMO person, but it usually is done quite smoothly.
Got it. It's been an absolute pleasure. I can't even tell you how cool I think this was.
Well, I'm glad you liked it. I enjoy it myself.
Yeah.
I have a great time doing what I do.
Sounds great. Thanks for joining us for another episode of Visions for Health. My guest today was Dr. David Danforth, who has a degree in clinical health psychology. Thank you.